My name is Liam McQuillan. I'm from Leopa, and we're here today to talk about our Shravy application. Hang on. So some of the fundamentals. Shravy is a lip reading application for patients with severely impaired speech, targeted primarily at unwell patients in critical care units. We've had an initial sale and we have active trials ongoing. We believe our total addressable market is circa $500 million per year, and the technology leverages our patent pending AI-based lip reading technology. Why Shravy? There are many medical conditions and procedures that severely impact a patient's ability to communicate. Tracheostomies, laryngectomies are examples. This inability to speak and communicate with their carers can cause patients lots of stress and can actually adversely impact their recovery. There are alternative speech generating products out there, but they're not usable by these types of patients. So the product itself, it can be downloaded onto a smartphone, invoked. The user points the smartphone towards the patient, the camera towards the patient. The patient will attempt to say something. Our technology will try to figure out what it is they're saying, return that in textual format, as you can see in the diagram here, or in the photo here. And then that phrase can be audified, so the patient can hear it. The patient is, very importantly, the patient's only required to move their lips, which is very, very well suited to these unwell patients in critical care environments. Just let me check the next slide here. So some alternatives to Shravy. There is, of course, the carer doing manual lip reading, but that can be exhaustive. And the longer it goes on, the more inaccurate it becomes. All technology-based competitive products are what they call grid-based, as you can see in the photograph. Essentially, the patient selects boxes from a grid that contain letters, words, or symbols, builds up a sentence, which can then be audified. Unwell patients in critical care environments, they just don't have the mental lucidity or manual dexterity to operate these devices. So very importantly, Shravy is very passive. It just requires the patient to be able to move their lips. We have very significant inbound demand for Shravy, both from hospitals and from individuals. We believe that every hospital with a critical care environment is a potential Shravy customer. Our primary target market is English-speaking regions with kind of high healthcare spend per capita and lots of critical care units. We are licensing the product on an annual subscription basis at circa £25,000. Progress to date, as mentioned, we secured a first sale of an early version of Shravy into an NHS health trust. We have active trials in 2 other health trusts at the moment, and also with the Vanderbilt Hospital in Nashville. We are Class 1 medical device certified and a multiple award winner. We're not actually looking for funding at this particular point in time, but will be towards the back end of this year. Our immediate focus at the minute is just on continued product development to attain higher levels of accuracy. We are looking to secure additional NHS sales this year, and we want to get to the point at the back end of next year where we have enough recurring revenue to attract a Series A round on good terms. So that's the pitch.
Let's turn to the judges and their questions. If you could use raise hand, which I know is a bit confusing in Zoom. Chris Cheney first.
Thanks so much, Liam. It's just, I think I should probably know this, but I just wanted to double check. You said you primarily English language. Are you developing other language capabilities?
Not at the moment. I mean, we're very much, I mean, we're a small company. We're very much focused on English at the moment. I let Fabian opine on this, but basically to adapt the models to a foreign language, it's not that much work. But to be honest, our focus at the minute is on English. We would see non-English speaking regions as a secondary market, and looking more at the kind of EU DACH region and kind of Middle East as targets there. Fabian, do you want to opine on the what's involved in adapting the models for a second language?
Yeah, the main barrier to using a second language is just the availability of training data in that language. So you need a large volume of speech data to train your models. One of the reasons for not doing it yet is just being able to prioritize that. So having a secondary language that's big enough that warrants the investment we'd have to put in to acquire the data, which is expensive and time consuming. The actual act of training the model is relatively simple. What we have done is do some proof of concept on small samples to show that it would work, and there's no reason why it wouldn't. There has been some interest of having secondary languages within the UK as well, because there's large communities of people who perhaps native language wouldn't be English, or they'd speak other languages. But so far it's just English, but there's no barriers to sort of doing that should the demand be there.
Thanks, Fabian. Next questions from John and then Rebecca.
No, thank you very much, both. And fantastic what you're doing in the ICU setting. Just really a thought about, have you explored sort of severe autism, learning disability? You touched on the grid type systems. And I was wondering if there had been, you sort of explored some sort of partnership in terms of augmenting that type of system. So you talk about some of the limitations, but actually what you're doing, you could potentially overcome some of those. And that is quite a well-defined market. So I wondered if you'd sort of gone there, so to speak.
I suppose a couple of answers to that. Firstly, our solution is our sweet spot really is folk who don't have the kind of manual dexterity to operate grid-based devices. If they can do that, generally they will use the grid-based devices. We also have, the reason for the product actually came out of ICU consultants. They approached us a couple of years ago, and they'd used grid-based devices and other types of speech generating technology within critical care environments, but they to no effect. And they stumbled upon our lip reading capability and kind of asked us to develop something like Shravi. So that's where it came from. There are, we've looked at conditions outside of ICU, like motor neuron disease and areas like that. But I suppose we do believe that these unwell patients in critical care environments is our sweet spot. It's a kind of a market that we can get to fairly easily from referrals from other, from different trials and what have you. So that's kind of where our focus is at the minute. Again, it comes back to one of the points where we are pretty small, and we can't do much by way of kind of parallel activity. We actually do have quite a large number of NHS and US hospitals that are keen to trial the device. We just can't service all those kind of trials concurrently.
Thanks, Liam. Lots more questions. So Rebecca, Rod, then Chris.
Thanks, Liam and colleagues. It was a really compelling patient need. And I usually ask questions about go-to-market strategy, adoption, and that sort of thing. But it sounds like you've got a super pipeline showing you've got great market pool. What did occur to me, though, is how do you, I'm just really interested to understand, how do you have to reach a kind of performance threshold? What's actually, presumably if you can tell if it's correct or not, and there's testing methods and that sort of thing. But you've got some trials, essentially sort of pilots, I guess, in some first applications. Do they have a kind of a performance threshold that they feel they need to see? And how does that work?
Yeah, so I suppose that there is, depending upon the the help, you know, what kind of state the patient's in. I mean, there are patients who are relatively lucid, and you know, when they use the system, it is very accurate. But you also have patients who maybe are intubated and have tubes over their mouth region and are kind of delirious, and you know, they have very, very feeble lip movement, and the product Shravi will not work as well for those. But I mean, we have, Phoebe, I don't know if you can quote can remember the accuracy stats we got from the trial with the Lancashire Health Trust. They were actually quite good. They were like,
yeah, we the way it works at the moment is the app returns a list of possible options and then in order, and it will vocalize the first one and the list automatically. So in terms of those three, if the right answer being in that top three, is the accuracy level is over 90%. What Liam said is true, but so the way to look at it is, for some patients, anything is better than nothing. So some of these patients are really struggling to communicate with any other technology. So there are other options. So if they can't use a grid and the eye tracking technology is tiring for them and expensive and complicated to set up, so this operates in some sort of middle ground. So we would argue that if it helps them get their point across, even if it's not perfectly accurate, it's always going to be some ambiguity with lip movement.
Yeah.
So it does depend on the target market. So if you've got someone who's like looking for speech therapy type thing, or is recovering from a stroke, they might be quite capable other than actually vocalizing words. So there may be better ways of doing it. So if you can use a grid and you're familiar with it, that's always going to be very quick and reliable. Mm-hmm. But if you're really struggling to communicate at all, then you know, anything that's close to what you said will do. So
presumably the hospitals have got they need to make a case. What's going to be their benchmark for making their business case?
Yeah, so interestingly, they haven't actually specified one, and a lot of these trials at the moment are, the way they evaluate these things is very much taking on board the patient outcomes. So one of the major things they use to evaluate it isn't necessarily the accuracy of the transcription. It's does it actually help the patient recover better? Because obviously a patient not being able to communicate has a detriment to their recovery. So I don't want
to cut you off, but I do have three more judges I want to kind of bring in.
Yeah, sorry.
Yep. Rod, Chris, and then Sarah.
I might speed this up because I think that evaluation of impact, is that based on the quality of care? I think you've just answered, which was going to be my main question. So my second question around that was, is this, you know, device specific, or are you looking at, you know, heads up displays, glass, you know, is
Absolutely.
there? Yeah. Fine. Okay. There's the opportunity to expand into that more seamless passive.
Yeah, my vision for this technology eventually is to just be in heads-up display on glasses, but I think that technology is still evolving. You know, Apple are entering this space now. I suspect we will be in a point where it becomes more socially acceptable to have these glasses. That's where we'd like to get it. At the minute, it's not tied to a particular source technology. So we use a mobile phone to capture the video, but in principle, it could be any device at all. If you can record a video of the patient speaking, we can do the transcription of it. So there isn't really a barrier there.
Okay.
Yeah, just, I mean, the trial we have ongoing in Vanderbilt, the Vanderbilt Hospital at the moment, it's patients are using iPads mounted on a stand in front of them. So it's
okay.
Yeah.
Yeah, just come in. Just going to shift the question slightly, because clearly there's lots of opportunity, and you've been developing the technology for a number of years. But I wanted to ask you a question about your main priorities for the business, and what are your biggest challenges?
Yeah, I mean, Shravi is our focus, really. I mean, it's we want to basically there are no technology-based speech generating devices for these very unwell patients, and we want to be the kind of, it's really a kind of an open market for us. There's no one else can play in that area. If we talk to providers of speech generating technologies like Tobii Dynavox that are one of the major grid-based suppliers. They just don't have an offering in there. So We feel if we can get the product accurate enough, that we will be able to. It's an open market for us. There is no other technology-based solution that will work there. I mean, the challenges in this are, we're selling into healthcare, and as you folk will no doubt know, that trying to sell into the NHS is a very difficult thing to do. Now, the way we've gone about that is we have a couple of very good relationships with ex-CIOs for different health trusts in the NHS, and they've helped us a lot in navigating through the kind of red tape and getting into these trials. And the initial sale that we made was we used folks in the know to get us in there. So it's our vision is to very much kind of dominate that space for these, provide a technology-based speech generating capability for very unwell patients. And I suppose I say the main challenge is just it's selling into healthcare, which is very difficult, but we've gone about it in a certain way that seems to be successful so far anyway.
Thanks, Liam. We could bring in Sarah.
So very quickly, I'm interested in your plan for scaling, where you say at the moment that you can't service all of your needs, and I can totally see why. As a nurse, absolutely, I can see the use case. So I just wondered what your plan is for scaling, please. And that's quite tight when we're quite tight on time. So I'm sorry that that's come now.
Yeah, I mean, our immediate focus is improving the accuracy of the product, and that's the focus for the next kind of 6 to 9 months. We do believe in doing that this year. We'll make a few more, probably 4 to 5, further sales of the product, and then we look at taking a kind of a large seed round that'll allow us to recruit the necessarily kind of sales and marketing personnel by the end of this year. And then hopefully that will lead to further sales to good recurring revenue streams, and then get to a point at the back end of next year where we're viable for kind of Series A funding on decent terms. So it's at the minute it's just it's very much improve the product, get some more of these initial sales, use that success to get a material seed round to help us build a few more sales pipeline, and then, as I say, be successful at executing on that and getting a Series A round by the end of next year.
I'm going to thank everyone. Thanks to the team for presentation and taking those questions.
So hi, my name is Dr. Julian Nesbitt. I'm working as an A&E doctor. I came across 9 patients in a row who tried to kill themselves. And on asking them, it was all because they're on a over 9 month waiting list to get support. The system is broken. The waiting list is just getting longer, and therapists are getting burnt out and leaving the system. So what can we do? Well, I thought, why aren't we utilizing technology to help this process? Just think, if we could make therapists' lives easier by giving them flexible working patterns and automating their admin, so that they actually have more clinical time with the patient. What if we could help patients by giving them customized, personalized dashboards where they could get access to the right self-help tools and resources personalized to them, and then empowering them to be able to match them with the right therapist for them, but giving them choice of who they want to see when they want to see them? And what if we could automate loads of back-end processes to make the whole system more efficient in an admin perspective? And then finally, what about using data to really personalize the care, working out what type of treatment is right for what individual? Well, that's what we've actually done. And over the last 6 years, we've built this platform, listening constantly and iterating to the feedback that we get from patients and therapists. In the last few years, we've really been scaling up rapidly at over 250% year on year, and is set to hit over 3 million now of revenue this year. And just based on current contracts, that's set to triple for next year. We've actually managed to do this, and having basically bootstrapped it whilst being able to halve the did not attend rate, double engagement, and improve recovery rates, and all while saving the NHS a third. So where are we going next? Well, obviously we're continuing to expand our technology-enabled service offering, where we provide the therapy utilizing our own therapist networks. But actually, because the technology has been so successful, many of the service providers have now asked to use our platform for their own service. And this platform, as I said, integrates this patient-facing side to this back-end electronic dashboard for the clinician and for admins. So this has actually been proven in a SaaS subscription basis with some of the largest providers in the country, and is now starting to scale. It's also had international interest. So you ask, why would they start using us instead of all the other electronic health records and case management systems? Well, we've built it in a modular, modern way, which is far more flexible and customizable, and also covers off the whole care pathway, unlike current solutions, which are just covering off little bits of it. So for instance, one large provider is actually going to be able to use us and not the 7 platforms that they're currently using. So just using ours that covers all of it. And then actually wanting to scale that across not just their mental health, but actually across their other modalities like physios and dentists, etc. So I think with this SaaS model, it has huge international scaling potential, obviously whilst still being able to provide our tech service. So thank you. Just to say, we're raising a 1.5 million round just to help really scale up our SaaS proposition, but we're actually nearly profitable, but want to scale faster. So thank you.
And John is hot off the mark. His hand's up already. So he gets first question. John, over to you.
No, perfect. No, thank you very much for that. The very quick question. What is the ratio of revenues from the tech-enabled services versus the SaaS business?
Yeah. So currently the majority is tech-enabled service, because our SaaS proposition is now starting to scale. So we've proven it out and now we'll scale. But yeah, we're looking in the next year or so, it should get more to 50-50. And then potentially the SaaS model will overtake that, as I say, that's faster to scale. However, having said that, because the therapists love working on this platform so much, and because they're leaving in droves from other areas, what we're finding is actually the rate of acceleration and actually the scalability is there, because therapists can work from home, we can utilize a global network, and actually, we're finding the amount of therapists wanting to join us and give us hours is actually growing exponentially. So I think that tech-enabled service model is also highly scalable as well.
Thank you. Chris Shaney and then Rod.
Julian, this is a layman's question, but I think you kind of touched on it a little bit. But have you kind of overcome, or have you struggled with the challenge of obviously different care providers? So you've worked in the acute sector, but the different kind of EPR platforms that the acute sector would use compared to primary care or mental health specialists, and how do you bridge across that?
Do you mean in the SaaS model or in the service? So in the SaaS, yeah. Okay, so interestingly, I'm not going to try and change the current electronic health records that the NHS are using, because I think that's a challenge that's going to take a very long time. However, what's interesting is the providers, and more the NHS is reliant on providers, right? They commission out to providers to provide these services. These providers aren't using incumbent large, old-fashioned electronic health records, and some of them, as I say, they're more innovative, and they want to sort of bring on board something that's easier to use, can integrate that patient side to the back end, which means you can collect loads of data beforehand, which means that actually the notes are auto-populating and making life easier. So those providers that are increasing, those are our targets, and also international. So I'm not going in now and trying to change a trust's electronic health record at this stage, because I think that's a step too far. But actually the providers are coming to us. I mean, we've done no marketing or sales across the whole business, and it's all word of mouth, and it is now growing exponentially because of the reputation that's getting out there. So does that make sense? It's the new providers that are supplying the NHS.
That's great. Rod, Sarah, then Chris Sawyer.
Hi, Julian. So from a proposition perspective, the virtual therapy is obviously part of that. There's obviously a key element of that in the digital therapeutics part. How reliant are you on the virtual therapy as the lead at the moment? And in the pipeline of digital therapeutics is, starting to develop, but we know, Germany and various others are sort of slightly ahead of where they, what is the support package around digital therapeutics, and how reliant on you on other companies developing those propositions for you to be able to then integrate?
Yeah, absolutely. And as part of our sort of modular offering, we can integrate very easily, and that's the point, to be very interoperable. So for instance, that would mean that if an organization that we're licensing the tech to has commissioned something, we can slot that in, i.e. as a digital therapeutic. We are actually sort of building our own. I think the idea for me is that we want to make the therapist's life as easy as possible. And we started by augmentation and getting more clinical time out of a therapist and just reducing the friction across that, and giving people access to the right type of treatment for them, or the right therapist, so reducing wastage. Now we're building things like digital homework tools that can just slot in. Things like that, just simple things that can be added in. That means that a patient can access that information much more quickly, much more easily. We've got resource libraries where the right information a therapist would normally prescribe, and things for people to have before, during, and after their therapy, they can access it via their personalized dashboards. And that way we can have them, so they might need less sessions. It means they can do their homework during the sessions, therefore they might need less sessions, and they've got support after the sessions. So we're starting with the low-hanging fruit, doing the simple things, and maybe eventually when the complex AI chatbot robots work, but my experience is we've overextended and we've promised the world, and it's not delivering yet because the market's not ready for it. I'm trying to understand what the market needs whilst thinking ahead to the future of what can be built in.
So you could offer the subclinical tools while you wait, but could you then also deliver a full IAPT pathway?
Yes.
Fine.
Yes.
Okay.
So there's automated triage. So I call it digitally assisted triage. So again, we can collect loads of data and information beforehand with customizable registration forms and chatbots that we've got our own forms that people fill in first. So that means they auto-populate the clinical notes of the therapist, which means that the actual assessment is a lot shorter. And then once they've been assessed, they can be put into the correct care pathway, whether that be step 2, whether that be step 3 CBT, step 4 clinical psychology, or EMDR, or whatever. We've got clinicians covering the bases, and then they can get personalized resources based on what their needs are in their own dashboards. So it covers off the whole of that care pathway, if that makes sense.
Thanks, Julian. And we can bring in Sarah next.
Hi, Julian. Just thinking that at the moment, this is adult only, isn't it? This is only over 18s. Is there anything within the pipeline to think about the services for?
Yeah, so we're just doing a pilot at the moment with Milton Keynes and CAMS. I think I'm trying to keep it above 13 for the moment, just because of the tech era. But as you know, children, teenagers, for instance, they love using digital tools and things like that. And we are also commissioned now via a partnership across universities. So together we're working alongside them, and they offer peer support. So again, we can sort of offer this whole package, and university students are using it. I think what's interesting, again, for me, it's about making sure that we've got the right clinicians, we're offering personalized care, and people are getting choice of the right area. But yes, children's are now, I say, we're piloting it, and hopefully we'll be scaling that as well. Different services we give, we can create the different white label versions of the platform for these different areas.
Thank you, Chris.
Yeah, so everything we've read and heard has been hugely impressive. But I have a question about kind of your business needs to support future scale up and to kind of exploit kind of future opportunities, and just kind of your thoughts around that.
How we're going to, yeah, okay. So I say the team, we've got a solid team now. There's 40 people in the team. I've got some very experienced people at covering off all of my weaknesses as a clinical entrepreneur, having not scaled the company before. We've got some very experienced business people that have come in. So I think we work really well together from that perspective. Now we're doing this fundraise, and again, I'm not doing a sort of massive Series A at this point, just because we don't need to. Our burn rate is very low. In fact, we could nearly be profitable with some of these new SaaS models coming out. We will be profitable, but I want to scale faster. And now that we've kind of packaged the tech, and it's taken 6 years to get to this place, we can package the tech in different use cases, and we're getting international interest as well. Randomly, a Caribbean island that wants to go from paper to our system just because it's new and modern, and they're leaping across multiple ones. So in order to scale in all these areas, we're going to need to set different teams up, and it's mainly around the technology and the tech team to allow that scalability. So our business needs right now is to really scale up that tech team, and potentially, having not had a sales and marketing function at all, with the SaaS model, we're going to need that as well, especially when we're going abroad. Now, as I say, whether I go to America now, I want to go to some more niche ones first, prove out the concept, and then go to America when we're ready, and not make that mistake of going too early, if that makes sense.
I was just wondering if kind of international was part of your kind of business strategy or not, but it sounds as if it's kind of an organic kind of growth type of thing at the moment.
Organic already, yeah. And then we're also having interest from the Middle East and actually private hospitals there. So as I said, the platform is for mental health, how it was built, but because it can be used for any clinician or any purpose,
kind of transferable.
It can be repackaged. And the other thing is it's far more flexible and customizable. So they go, why aren't you using this big incumbent EHR or whatever? Well, no, because they're not flexible at all. But because we're modular, we can build extra modules if they need to, and then have that in a back to give to others. But we're still scalable because the modules can be slotted in. So I think that's really exciting.
One last question from Rebecca.
It's really, Julie, it's super to hear how it's growing and how you've got the pull and the market demand and everything. Could you just give us a really, really simple pencil sketch, because I haven't really picked this up yet, on how many customers you've got and what the revenues are, and then the growth rate on both, sort of what's sort of happening, you know, where are you in the sort of scaling already?
Hang on, let me just do this. Hang on 1 second. Can you see that slide? Okay, so
I apologize, I didn't pick up the exact numbers when it
no worries. So we're going on to, well, we're now at for instance, this month it's gone for, last month was 250k, this month is 350k month to month revenue, so that's scaling up 250-300%. Revenues for this year are 2.73 million. Revenue last year was 1.2. Just on current contracts, we should actually triple that revenue next year. And again, this is sort of on bootstrapping it. We're currently servicing 25 NHS trusts with a pipeline of others waiting to come on board as we accelerate our adoption as we accelerate our recruitment of the therapists, setting up new services, as for instance, the children's ones, scaling across universities, as well as we're now supporting occupational health and health insurers as well, and moving on with that SaaS side. So lots going on, and we're diversified. And I think for me, the SaaS is about owning the infrastructure and controlling that infrastructure play. And actually, you've got then a hybrid approach where people aren't coping, they need extra support. Well, we've got this massive network. So use the infrastructure of the platform, and we can plug and fill gaps as and where needed. And again, that's how we can truly provide personalized care with choice, is my vision.
Brilliant. Thanks, Julian.
My name is Umar Naeem Ahmed. I'm an NHS doctor and I'm the CEO of Aptrace. And the reason we created Aptrace was because we felt that rather than waiting for a patient to end up in hospital or get ill enough that they need their GP, we needed to tackle illness earlier in the process, if we were ever going to get on top of the backlog and the workload for the NHS. And so we can monitor existing disease better, make sure people get the right tests, detect cancer and other diseases as early as possible, and to put people even earlier in the process on preventative processes and avoid disease altogether. And this is a huge task because this affects the whole population, and yet each of these patients need individualized care and treatment depending on their combination of conditions. But if you look at GP today, despite best efforts, there are 6 million patients that are overdue monitoring. And if you look at what happens in an appointment, 2/3 of appointments, according to our data, are suboptimal. So people come in needing a certain group of tests, and they walk out having some done, some not done, and then you need to bring them in for another appointment. And so if you got this right, you could save the NHS 30 million appointments in primary care a year, and that is 30 million appointments we sorely need. And this is why Aptrace has grown very quickly to covering 4% of the UK population. And what we're asking to doctors to do at baseline is you're asking them to see everything, to know everything in the EHR, in the electronic health record, to process that against clinical guidelines. And therefore, we're ending up with a very manual process full of duplication, full of repetition, and it's not good for patients, it's not good for healthcare systems. And yet, what Aptrace can do is we can integrate into 96% of the UK health record. We can encode through a UKCA marked clinical device. It's a safe delivery of these guidelines, and then we can improve processes, whether that be for monitoring disease, detecting new disease, or preventing disease altogether. And it's working. So we've shown that practices that use our product are able to get on top of their backlog faster than practices that don't. We've had great user feedback, and we've had impact in utilization and now procurement. And it's not just monitoring of disease. Our early detection of cancer algorithms using proprietary machine learning technology are detecting cancer in our in silico validation 1 month earlier and at 50% positive predictive value. And we're also building tools for integrating wearables and patient communications to help with that prevention piece. So essentially, it's a platform that's utilizing the promise of electronic health record data. We've also been out to the Middle East and had great interest from the Emirates Health Services in Saudi Arabia and also the US market. So it's a problem that's not just shared in the NHS, but the NHS is the best possible place for us to prove the promise of this approach, individualized patient care at population scale. So briefly, we've gone from a revenue last year of 34K to 485K so far this year. We expect to get to £1 million ARR this year. We expect at the end of the year to be covering 5 million patients and provide NHS savings of £50 million a year at that footprint, and as well as bringing the cancer product to market and preparing for future market entry.
Rod first and then John.
Hi there. Just it may be a clarifying thing. So can you just talk through what the user experience is? So from a GP sitting, is it part of the consultation or is it something that's happening background? Just to clarify how it works and how, as a GP, I'm using this in conjunction with other, EHR type platforms that I'm using.
Yeah, absolutely. So it functions as an integration into the EHR. So as far as the user is concerned, it's just another window that appears and you can launch from your EHR directly. And it says, for this patient who's sitting in front of me, whatever reason it was that they came to the practice, they should not walk out unless they have these things done. So it analyzes their record. So it's not necessarily the GP, actually, it's the healthcare assistant, it's the receptionist, it's the member of staff who can't make that judgment themselves, but now they have a clinically certified recommendation. And so the way the practices are using it is, don't let this person walk out until you do all these tests. And secondly, it's also about who do we bring in? So looking at it now from the user perspective of a partner or a practice manager, a more senior person is saying, this is your entire 10,000 patient population. These are the 6,000 people that you need to do something about. These are the most urgent people. And how can you meet that demand and prioritization to capacity? So bring them into the right member of staff who can make sure that once they get in front of them, they'll get all those things done. So if somebody needs a nurse, you get them to see a nurse. If they can get away with a healthcare assistant or even do it from home remotely, do that. And you then therefore you get that additional optimization. So that's how the two ways the users would use it.
Thanks, John.
Yeah, this is really interesting from sort of a health economics perspective. Can you talk a little bit more about how things have worked in the cancer pathway? The specific cancer types and sort of where do you see it going?
Yeah, so I guess the great advantage of our tool is that what we're trying to do is to raise suspicion earlier. And therefore, it's not a diagnostic for cancer, but it's saying, can we make that GP refer that patient a month earlier? And if we do get it a month earlier, and this is what our data is showing, then you would have, on average, a 10% reduction in mortality for cancer. Obviously, that varies depending on the cancer type, but we're cancer agnostic. We're not focused on a particular cancer subtype. What we're trying to pick up is, and it does work better for some cancers than others. In fact, it's more effective for those cancers where the signs are subtle. So pancreatic cancer, ovarian cancer, where it takes longer for us to become suspicious and make that referral. But on a clinical impact point of view, you're talking about a 10% reduction in mortality every month you make that referral earlier. And that's what we're showing. And also the other question is, how good is our recommendation? So we don't want to be perfect, but we're getting one in two recommendations that seem to lead to a genuine referral requirement. So GPs are getting recommendations that they can actually make use of.
Thanks very much. Next, Rebecca, and then Sarah.
Can I dig in a little bit into what you described as the sort of user experience translates into the value proposition for your customers? Is the skeptic in me thinks it's a bit of a fallacy that intervening early kind of reduces back burden. I'm sure you've heard people say that before, because the NHS was built on the idea that if you have an NHS, you wouldn't need healthcare. There'd be a reduction in the need for healthcare, and that sort of hasn't quite worked that way. So I just wanted to understand how's it. But you've got data that's showing it's in helping GPs get through what they need. So how is that translating a little bit? So what's the actual value proposition?
So I'll answer that in two ways. The first question, I think, is about the value of preventative care. And I think that what we're basically saying is that, often this is said about reactive care, that if you made available twice as many appointments, you get twice as many people booking in for an appointment. But part of, we think, the way of dealing with, often the focus is on that reactive care piece. But if you have a healthier population, if you intervene on them proactively, you bring them in rather than them calling you, then actually in a way it's more efficient. And there is data to suggest that where people feel that they're going to be called in advance, they're less likely to initiate an appointment. So there is an impact. And that's why we think the focus should be on that proactive care piece as a general kind of health evidence base. Specifically to our product, what we've shown is impact on evidence-based intervention. So we know that diabetics should have their renal function checked, and that's based on evidence. And we can make sure that that renal function is tested for a population. More people are tested, more people are being monitored, but with fewer appointments. We're improving the efficiency of a process for which there's an evidence base already. We've not been around long enough to show that those practices that use our product, we know that their patients are being better monitored and they're spending less money. We don't yet know that those patients are going to A&E less, for example. That's going to take time to establish. But I have to say that very few interventions can demonstrate that potential, at this stage. But I think that's why we think in the future, and that's why we think as NHS as a first market means that if we do get this right, and we think we will, then that's a model that will become very attractive to other healthcare systems, because effectively the NHS has already started on that journey. We think that digitization will allow that journey to be completed. And also, more importantly, we can collect the data and measure our impact using all of our integrations and capturing these processes.
Thanks, Umar. Next, Sarah, then Chris Sawyer.
I suppose mine's on a similar lines, actually. What percentage of patients that the clinician clicks on to see if there's anything end up with extra tests? And therefore, what's the GP's response when actually, presumably, there's quite a funding link to that?
Yeah, so by definition, we don't ever make a test that wouldn't already be done. So by definition, it's not that they're getting more tests, it's that rather than having 2 or 3 appointments in the year to achieve the same number of tests, they're having them in one go. So rather than sticking a needle in someone's arm 3 times a year, you're sticking it once, you're collecting 1 blood bottle. And for the GP, they're getting all those results. They might be reading twice as many results, but it doesn't take much longer to do that. In one, the patient sends you a bunch of results, rather than opening that record 3 times a year and then reviewing the renal function the first time and the full blood count the second time. So actually, by combining it, you're getting a significant efficiency. And by definition, we're not recommending anything that wouldn't already be done or shouldn't already be being done.
Thank you. Chris Sawyer.
Yep. So this is a scale-up competition. Where do you see the business going, and how big do you see the opportunity?
So in the UK alone, with the first product alone, we expect the initial market size to be £40 million a year. And if you take into account the cancer product and the preventable product, that rises to £600 million a year. But that's just the UK. We're already talking to other markets, the Middle East in particular, high burden of chronic disease, advanced EHRs. We're on the Department of Trade and Industry playbook. We've been out there. We're going again next week. So we're one of the UK companies that's being promoted, and also in the US. So we think that there is, the NHS represents an opportunity where we will get to 10 million ARR, that's the target, before we significantly invest in other markets. But in terms of VC fundraising and so on, what we want to have is an MOU by the end of the year in one of the second markets, whether that's the US and the Middle East. And that will demonstrate the need.
And how competitive is the market, and how differentiated is your solution?
So fundamentally, in the UK, and as far as I know in the world, we are processing more primary care health records than any other company I know again, for the purpose of care delivery. We're not an analytics research company. We're helping clinicians deliver care to patients. So, our differentiators are integration, going through all the governance, being able to hold a very vast number of records, and then users. We've got 4% of the UK GPs signed up to us, which again each time we do that, it builds and it's the same product that's being scaled up. And when you come to go into the second market, the Emirates Health System is interested in taking products from the UK, but they're interested in taking validated products. And we can say to them legitimately that a significant part of the NHS uses us every year. And the NHS is a very respected health system. And similarly in the US, what we want to be able to demonstrate is some of the other questions we're talking about, the proof of the value proposition. So what we want to go to a managed healthcare system in the US and say to them is that your challenge is measuring value, and you have lots of different stakeholders within that value chain. What we've demonstrated with the NHS, which is a simpler value chain, is we give us 1 million patients, we will look after them for a year, and this is the health outcome you get. This is the efficiency appointments you get. So hopefully that is a proposition which means even in a more challenging market, which the US is, with obviously lots of players, we can get to a scale and an evidence base that makes us an attractive proposition.
Okay. And just if we got time, regulatory barriers?
So we spent the first 2 years of our life just sorting out every single regulatory barrier, ISO certified, on the HSCN, UKCA marked, CE marked. We've never had an issue with any of the ICSs that we worked with any regulatory requirement that's pending for the last year. We've done them all. There are more to do in the US, of course, and also in the Middle East. We're well aware of that. And one of our founders is very much focused just on that. So that's never been a rate limiting step for us. It's hard, but we know how to solve those problems.
Thanks. Thank you.
Just a question on integration. So it's a limited kind of market of primary care EPRs in the UK, 2 main providers. Are you integrating with just one of those providers, both of them, or a larger number?
Both. So we're covering both EMIS and TPP. So effectively, we've got almost all of the UK from a primary care perspective. What we've now started working on is Cerner and Epic, both for secondary care integration in the UK, and then Cerner and Epic often provide primary care in other markets. So, but actually, as far as our primary care market and 56 million people in the UK are concerned, the integration is complete. We don't need to do any further.
And are you integrating with data at a practice level or at an ICS level?
So ICSs or larger bodies will often procure us, but then we connect into each GP because we're helping the GP practice provide care. But it takes us an hour to make a practice go on board. So those pipes are built. It's just a data protection thing where each GP surgery has to agree that they will use the product and they're happy for us to process the data on their behalf. So we don't sort of go live across 20 practices at the same time. They each have to click a button. But yeah, so there's a kind of commercial aspect and there's a data protection aspect.
That's great.
Vine Health provides remote personalised support to cancer patients, and in doing that, we gather really rich longitudinal PROMS data to inform better cancer care. Vine Health's mobile app helps patients to easily track, manage, and understand every aspect of their care. It delivers evidence-based, trust-specific patient information, clinical alerts, and tailored psychological support. Our service-specific prompts support patients to seek help at the right time from the right channels, thereby improving patient care and reducing burden on clinical workforces. And in supporting self-management, the app gathers rich longitudinal PROMS and red flag symptom data to inform stratified follow-up and facilitate more efficient follow-up with clinical teams, including virtually. The data can be rapidly deployed into clinical pathways using our clinician portal, which is fully interoperable with NHS systems. So why is that important? Well, the research shows very clearly that incorporating PROMS data and personalised care supports much more timely clinical decision-making and leads to improved service efficiency and dramatically improved patient outcomes. All reasons why these are a core focus of the NHS long-term plan in oncology. Vine Health's technology has been successfully implemented to achieve those exact benefits throughout the cancer pathway, from the pre-treatment stage, where we deliver carefully personalised information and signposting and pre-MDT evaluations like frailty assessments, to treatment, where we deliver longitudinal toxicity and adverse event monitoring, H&As, we support acute oncology service triage and long-term PROMS collection for immunotherapies, to long-term follow-up, where we can support with long-term side effect monitoring and patient-initiated follow-up. And we've shown that we can do that in practice with numerous leading cancer centres. Our recent work with the Royal Marsden, funded by NHSX, demonstrated excellent engagement, including 100% PROMS data collection, way above the standard of 3 to 15%. 87% of patients reporting significantly improved quality of life and significantly improved medication adherence as well. So in summary, we all know the challenges presented by an increasing cancer backlog, constraints on clinician time, poor quality of care, poor patient experience, and recurrent ED admissions. Vine Health is actively solving these challenges across the NHS by streamlining services, enabling clinicians to see, preempt, and rapidly address clinical deteriorations, to deliver effective remote care, and put control back into the hands of patients with initiatives like patient-initiated follow-up. And we're not just another app, we're a CE marked Class 1 medical device based on our usability, accessibility, and data governance. We've been rated 93% by Orca, making us the highest rated cancer tool in the UK. The UK's foremost oncology clinicians have fed into every aspect of platform development alongside our patient advisory board, and we really have support from across the ecosystem, partnering with almost every leading cancer charity, many NHSNs, supported by NHS England through their National Innovation Accelerator, and we're putting the platform already into action with nearly 20 leading NHS cancer centres. We've had brilliant feedback, particularly across all ages, that the technology is intuitive and easy to use because we've specifically designed it for inclusivity. It will be suitable if you're colourblind. It will read out loud to you if you're sight impaired. You can loop in caregivers and loved ones. It's suitable if you have low health literacy or English not as a first language. And clinicians report that having this information easily viewable makes consultations and care delivery simpler and faster. And we've fully scoped the expected cash and non-cash releasing savings associated with longer term use of the platform. Per 1,000 patients, you can expect 26,000 fewer admission days per year, 50 fewer A&E admissions per year, and significantly improved patient outcomes. We've raised 6.5 million. We've reached 1 million in annual revenue. We've grown our team to 30, and our product is ready to scale across the UK. We're really excited to continue that journey with your support. Thank you.
Okay, I'm going to ask our judges to put through their questions. John was hot off the mark, but Chris didn't go last time, so I'm going to go Chris first, then John, then Rebecca.
Thanks, Rena. So I'm familiar with Vine. You guys have for a number of years been seen as a real exemplar, I think, in the digital health space. I just want to be crystal clear what you're hoping to achieve kind of through this process. So is your direction of travel wanting to move into the kind of like the more kind of primary and secondary care space? It's really I'm just not quite clear where you're hoping to go and how this is going to be.
Yeah, so I mean, really our ambition is to make sure this technology is available to as many clinicians and patients as would benefit from it. Chelsea and Westminster is clearly a leader in that kind of digital innovation. It's not a organisation we've partnered with so far. And what we found is that although there are certainly big learnings that we've taken from one hospital site to another, that's always a process that improves the technology, improves our ability to deploy seamlessly, and improves our understanding of clinician pain points. And so it's really important to us to keep learning in that. And I think the opportunity to pilot with Chelsea and Westminster and understand how we support an organisation of that size would be a really valuable opportunity for us.
Thank you. Rebecca.
I'm going to ask two very, very simple questions, I hope. One is, you've got $1 million of revenue at the moment. How many customers is that? And the other question is it the same across all different types of cancer? I mean, are there variations?
Mm-hmm. Yeah, so on the first, we have about 4 or 5 different customers in that. We certainly have a big concentration of revenue. We have part of our revenue coming from providers and part coming from pharma. So a big chunk of that is pharma funding programs that are delivered by the NHS. Just a caveat there, we don't kind of share identifiable data with pharma, but they are simply interested to support patients on their drugs in collaboration with NHS partners. So that's a part of our revenue. In terms of how we operate in different cancer pathways, so we've built the platform to have really clear self-serve customizations by the providers that are using it. So they can decide, let's say, for their low-risk post-surgical breast cancer patients, that they want X information to be delivered, that they want a certain prompt to be delivered at a certain frequency through that journey, that they want certain alerts to be attached to symptoms of a specific, over a specific threshold. So all of that can be set up really simply by the caregiving team in accordance with what's most useful. And that's a big, I think, differentiator between a lot of other systems that they've used in the past, which can be generic and cause endless sort of pinging to the acute oncology nurses and overwhelm them. This is really set up in a way such that clinicians can decide what's useful for them and tailor it to their own threshold of capacity, but also what's relevant to that particular pathway in those particular patients.
Thank you. I got slightly out of order there. It's John. Otherwise, he's thinking I'm being undefined.
Yeah, no, thank you, Raina. You've touched on this a little bit already, but I think the current thing is, what is the sort of the ratio of revenue from NHS provider and pharma today, and where do you sort of see that going in the future?
So it's predominantly pharma. I don't know the exact figure off my head, but it's probably sort of 90 plus pharma and much less NHS. But the reason for that is that the incentives are aligned. Pharma's interest in funding this is that they know they have drugs that are by definition toxic in cancer, and that in order to achieve the effects that we know these drugs can have from clinical trials in the real world, there's a massive drop off between those two, that they need to be delivering digital support, and the acknowledgement that actually NHS trusts are resource constrained. There are limitations on workloads. And so it's of interest for them to be supporting clinicians and supporting patients on those therapies. And for the NHS trust that we worked in, it's an advantage that we have a sustainable revenue model that means they get to deliver this technology, but they don't have to fund it out of their own pocket. So it's really a win-win. And as much as we can fund this from life sciences who have an interest in making sure that their drugs are taken well and patients on them are supported well, we're keen to keep doing that. Certainly in other geographies, for example, we're launching in the US at the moment. There is more interest in paying that from a provider side. And we do offer that to NHS Trust to work with us directly. We've done it with a couple of providers. We're doing it with, for example, a Bupa hospital. But there is that advantage that if budgets are low, they can still benefit from the technology.
Thank you. Sarah, then Chris.
Thank you, Raina. You mentioned about the fact that you want to get it into as many clinicians' hands as possible. What are your barriers to that, please?
I think timing of working with NHS Trust, necessarily that process is long. We often go through months plus of kind of information governance and backlogs there. Often these processes have a lot of administrative burden on them from both sides. And so that process takes a long time. That's, I would say, the main barrier. Often we have great support from clinicians, but there's often a lack of clarity, I would say, in understanding how to implement something and go through the sort of management side of that. And so it's really about just navigating who the right people are within an organization to involve and how we navigate sort of backlogs and things like IG. Those are probably the main barriers that we come up against. I mean, certainly we've been through all the regulatory certifications and hurdles that allow us to move through that process really quickly once we're in it, but often it's the delay in getting into it.
Thank you, Raina.
Thank you. And Chris.
Yeah, so this space is really competitive. What's your USP?
Yeah, I mean, we have really, really focused on usability and accessibility for patients. And we've done that in a way of, very unusually, our most active users, the over 65, it's very unusual. The app will genuinely read out loud to you if you're sight impaired. It will mean you can loop in caregivers and loved ones. It will be suitable if you're colorblind. It's available in other languages. It's really accessible. And there are other kind of players in this space, but I think you only have to look at the ORCA ratings to see how far above and beyond we've gone in both patient and clinician feedback, usability and accessibility, and data governance and security. We are 10+% above on all of those things in ORCA. So, I would look to that kind of objective independent evaluation as a marker of how much we've invested in those things.
Rebecca.
Can I ask about the financing plans? So where are you at the moment, and what are you planning next?
Yeah, of course. So we raised our first venture capital round in mid-2019. We raised a second one at end of 2021. Our runway is to about the end of 2023. And so we'll be going out to raise the next round in the next quarter. That will be likely a Series A, and it will finance some extra product kind of development metrics that we have planned, as well as expanding our language base. That's been really important to a few of the NHS trusts that we work with, as well as expanding internationally and improving the kind of personalization that we can do in various ways within the app.
Thank you. Hi, Chris, you've got another question.
Yeah, it's just follow on to that one, just for clarification, really. In the application, I'm sure I read that you were looking to raise £50 million. Was that correct, or was that an error?
50.
Yeah.
No, I
application.
think that is an error. I'll take a look at that. No, that's not the expected number. We haven't launched our fundraise yet, so we haven't announced a figure publicly, but we certainly will be soon.
Okay.
If we've introduced that error, apologies, Raymond, that's quite possible. I've got a question I wanted to ask. You're doing huge amount of your kind of revenue coming from pharma. Are you white labeling the platform, or do kind of patients that are experiencing it paid for by a pharma company experience it as Vine?
Yeah, it's a good question. No, we don't white label it. It's all under the Vine Health branding. When we work with an NHS trust, often it's branded with the logo of that NHS trust, so that they know it's coming from that care team. And if there are particular parts of it, so for example, in a patient support program, there might be drug specific information or information about adverse events to look out for, that kind of thing, that will also be branded with the pharma company that it came from, or who sponsored that program. So it's clear where information has come from. And similarly with, there's lots of information in there from CR UK or from Bowel Cancer UK and so on. So everything in there is labeled as to where it's from. But actually what we found is that pharma companies don't want it to be fully branded as a sort of a life science partnership, because there is that skepticism of what is their involvement, and we make it very clear, this is information they've provided and funded the delivery of the platform, but actually this is a service that is coming from your care team, and it's aimed to kind of improve the quality of your care, as opposed to being sort of a link with the pharma company. So actually they haven't been keen on branding it themselves. They understand the benefits of something that is appealing to patients and is most closely linked to their care provider.
Brilliant. Thanks so much for your presentation.